Hearing impaired is another high-risk group because, again, communication is difficult. And so we need to have special kinds of training to work with this particular population. The same is true for language and communication impaired people. Our skills are using language, are using our treatment, our therapy, which is a talking therapy. So if we don't have good communication with our clients, it's going to be very difficult for us to be successful. We also know that it's true working with people of different cultures. Multicultural training today is essential. Many of us who were trained years ago weren't trained necessarily in understanding the differences that people have in different cultures about what they might say, what's okay to talk about in treatment, or in even seeking treatment in the first place. And so multicultural training is critical, and the people who come from different cultures are high risk. This is also true for people from a different culture who are here in this country without legal status. Again, their fears of their lives being disrupted often stand in the way of their receiving necessary psychological interventions, and we need to be sensitive to that. Same is true for people who don't have money to seek our services. Psychology and psychotherapy is changing. There was a time when most people who received psychological services did so from private practitioners, and it was covered by third-party insurer payers. Today, that's not true any longer. More and more psychologists are working in sometimes called medical homes, where you're working with a group of other professionals, and we're learning to provide services, particularly for disadvantaged folks and folks who don't have financial resources and don't have insurance, medical insurance that's going to pay for our services. So a lot of the work that we did back in the 70s and the 80s to try to get medical insurance and coverage is being undone today. So providing that kind of services is important. Now, people who have had that financial ability and then get into some kind of difficulty financially, which is not uncommon in our country today, with so many people being out of work, and we know that medical insurance usually goes along with people's jobs. In those cases, we have to be very careful that they don't go into more serious depressions than they might have otherwise. So they're definitely at high risk. And of course, as I was saying, the lack of medical insurance just keeps so many people who could be helped by our services away from us. And so we hope that many of you may belong to your professional associations, where many of them have set up pro bono groups so that you can provide services. If everybody provides a little bit of services, we'll be able to cover more people than if it all rests on just a few people's shoulders. So we also know that managed care is high risk for many of our clients, especially the managed care clinical culture. Mentally ill individuals are usually not able to deal with the bureaucratic roadblocks that are often set up by these managed care organizations. It's absolutely a system error. It's not about the individual, it's about the roadblocks put in front of individuals so they don't get the care that they need. And oftentimes we need to be their advocates. We need to understand what's happening, help them understand that it's not their problem, it's not their fault. It ends up being their problem, of course, because they don't get the services that they want. But we need to help them find advocates to get around some of the bureaucratic nonsense that goes on. Oftentimes, chronically mentally ill clients get a runaround from these organizations. They don't want to provide the kinds of care that they need, and the problems often are multiplied when seriously mentally ill individuals stop taking their medication, which we know medication isn't the answer for everything, and it doesn't always make them feel well. And so oftentimes they are feeling better and they don't want to take the medication because of the side effects. They stop taking it, they slide downhill again, and need the cycle needs to be fixed. And sometimes when that happens, because they didn't keep their appointments or because they didn't follow the rules that some of these managed care organizations have set up, they're not seen again. And again, they need advocates to help them get back into the swing of services. So these kinds of managed care organizations, some of us belong to them, some of us don't. It depends on whether you can deal with the kinds of roadblocks and issues, especially when they're believing more in how much money they're going to make rather than how much care they're going to provide. Sometimes I think if we changed the culture and we said a managed care organization would be rewarded for more care instead of making more profits, we'd have a healthier society. So we need to really work with patient advocates and maybe become patient advocates ourselves. The clinical culture certainly can use that. Mental health providers who encourage patients to take responsibility for their own actions may inadvertently cause these same patients guilt feelings when their problems are really system errors. So we have to be very careful that we don't put the responsibility back on our patients when we know it's really the managed healthcare organization that's causing us the bureaucratic difficulties. It's also important not to dismiss system errors as a defense mechanism by clients and instead study the clinical culture's role in perpetrating the errors. That's particularly when it comes to the errors in getting clients the care that they need when we know what's going to happen, when we can in advance understand that particularly the chronically and seriously mentally ill, are going to have a hard time in following the system regulations, and that we don't dismiss them because they're not being able to follow regulations that shouldn't be made in the first place because they're not appropriate for this population. So let's take a look at some other areas of medical errors. I'm going to turn it back to Dr. Shapiro, who's going to talk about risk assessments.
Yes, I'm going to talk about risk assessments in terms of suicide. Suicide, of course, is a serious adverse event, a sentinel event. But we have to, again, look at the system errors that might lead to it. So we need to look at the need for all mental health professionals to become familiar with suicide assessment literature. There is a lot of it out there. Some of it talks about different interview techniques, different tests, different combinations of tests and interviews. It doesn't really matter which one you use as long as you use one of them and use it fairly consistently. It is important to incorporate this assessment into all intake interviews. I underline the idea of all intake interviews, not just those where the presenting problem is concerns about suicide, but really all interviews should have some of those components and dictated by the kinds of questions, the kinds of parameters that we know from the literature. The importance of taking a careful history cannot be overemphasized. There was for a while in psychology a school of thought that said, well, I don't care about history. I just deal with the here and now, how the person is presenting, is interacting with me right now. And they would say history is irrelevant. Well, history is not irrelevant. History is incredibly relevant, especially when you're dealing with a behavior like suicide, suicidal thinking, suicide attempts that have gone on in the past. So you have to take a careful history, and especially if there was any evidence of suicidal thinking, suicide attempts, even suicide gestures in the past, you have to continue assessing for this in each clinical session that you have. Again, following the standard of care, which means being aware of what that literature talks about, and taking action that to prevent something that would be reasonably foreseeable. Now, reasonably foreseeable is a term that occurs a great deal in the law. What it basically means is that a well-trained clinician following an appropriate documented standard of care would find that particular behavior reasonably foreseeable. You need to promote a sharing of best practices, and this is where we get to the system errors. The system has to build that in, to have some sort of continuing education, conferences to learn about suicides, protected registries, research funding related to suicidal risk, especially in minority, pediatric, and adolescent populations. These are populations where it really has not been studied all that much. Dr. Walker will talk about some in adolescent areas. There has been some research in there, nowhere near as much as in adult populations. In minority and pediatric populations, very little research. And also have to look at research on the impact of suicide on families and providers. So I want to turn it back to Dr. Walker just briefly to talk about adolescent suicide prevention, and then I'm going to talk about other kinds of violence.
Thank you. Adolescent suicide prevention is a little bit different from adults. First of all, we know that depression in children often manifests itself in different ways. In fact, in sometimes, a depressed child is the child who's acting out all over the place. So it is indeed possible that depression is not, or what looks like depression, is not always a precipitator of suicide, especially with children below adolescence, the pre-puberty children. So we have to be careful. Now, suicide is not frequent in terms of base rate with young children, but when it does occur, it's usually because people missed the signs. They weren't the typical traditional signs that we look for in suicidal behavior. Of course, the most important is to listen to the child. Because in many of the research studies, children have talked about committing suicide prior to actually doing so. Not all, of course. In some, there may have been signs, but people just missed it. That's also true for adolescents as well. It's much more often that adolescents who suicide are coming from families where there is either some kind of dysfunction, or there may be physical or sexual abuse, or there may also be substance abuse in the family. We also see some adolescent suicides when they're beginning to develop the symptomatology of schizophrenia. We know schizophrenia, some forms of schizophrenia begin to develop in late adolescence, mid or late adolescence, and sometimes kids just can't handle those symptoms and don't know what's happening to them, and nobody really picks it up, sometimes because they don't actually tell people. Now, more recently, we've also seen some suicides with children who have been bullied and couldn't tolerate the horrible bullying, or we've also seen it in gay children who could not tolerate the teasing and bullying and lack of support for their sexual orientation and identity. That's different from other adolescent kids. So these are the kinds of high-risk things that we want to look for in adolescence. Children that have suicidal ideation, that think about killing themselves, high risk. These are the same kinds of children that we want to talk to and look at their behavior, make the kinds of suicide pacts that we do with adults. If a child talks about suicide during childhood, it creates a higher risk for them to actually be suicidal during adolescence. They're much more likely to be able to be completers, suicide completers, as adolescents than they are young children. And the research shows that almost 60% of teenagers who reported suicidal ideation or behavior were not identified by school staff who saw them daily. So identifying a suicidal adolescent is not an easy thing to do. And we need to do better training in the schools and other institutions that work with children so that they can identify some of the different types of signs that these children are in trouble.